Hello, and welcome to Noon Conference hosted by MRI Online. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all, and is an opportunity to learn alongside top radiologists from around the world. We encourage you to ask questions and share ideas to help the community learn and grow. You can access the recording of today's conference and previous Noon conferences by creating a free MRI Online account. You can also sign up for a free trial of our premium membership to get access to hundreds of case-based microlearning courses across all key radiology subspecialties. Today, we're honored to welcome Dr. Soonmee for an update on imaging and 2021 WHO CNS Tumor Classification. Dr. Cha completed her neuroradiology fellowship at New York University Medical Center. She is a neuroradiologist with special interest and expertise in brain tumor imaging at University of California, San Francisco Medical Center, where she also serves as the program director of diagnostic radiology residency and the vice chair of education. At the end of the lecture, please join Dr. Cha in a live Q&A session where she will address questions you may have on today's topic. Please remember to use the Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we're ready to begin today's lecture. Dr. Cha, please take it from here.
Thank you for the nice introduction. I will share my screen. Is it okay to share now?
Yes.
Okay. This will stop other screen sharing. Do you want to continue? Yes, I want to do that. And then if you could just let me know if the screen looks okay from your end.
Looks great.
Okay, great. Well, thank you so much for having me today. Hello, everyone out there. I'm going to talk about some brain tumor imaging in the context of WHO CNS Tumor Classification. I don't have anything to disclose. So objective today is I'm going to highlight a couple of key points from the 2021 WHO CNS Tumor Classification and really morph that into how is that relevant to neuroradiologists or general radiologists who are looking at brain MRIs or spine MRIs for patients with brain tumor. And I'm going to just illustrate some of the correlation of molecular genetic markers in terms of what are you looking for on imaging, because we're not neuropathologists, we're not basic biologists, but we must keep abreast with this explosive knowledge coming from the biological side because it does have implication for imaging. So the three things that I'm going to highlight is WHO CNS classification and neuroimaging techniques that most of you are very familiar with, but put that in the context of the molecular generic era of brain tumors. And then I'm just going to show you case by case how things are relevant. Imaging and neuropathology, neuromolecular genetics are intertwined. So first, let's start with CNS WHO classification. So some of you are already familiar that World Health Organization has been supporting classification of not just brain tumors, but all tumors. For CNS tumors, the first version came out back in 1979 and 2000 up to 2007. And these four classification schemes were purely based on histological. And then something magical or something really groundbreaking happened in 2016 classification, where molecular genetic information became part of the official classification system. So no longer just the histopathologic features of tumor was used to classify tumor. Now there's this very, very advanced technique looking at molecular genetics. But more interesting to us radiologists is that for the first time ever, since 1979, MRI image made it to the cover of this book. And then fast forward 5 years later, 2021, WHO classification, the 5th edition was published, and you could see that now we have 2 MRI images. So imaging is now really gaining attention to our neuropathology and neurobiology colleagues, that imaging plays such an important role of how we actually look at tumors. So we are well on our way to becoming a very important, but now we are pushing towards being part of the classification of CNS tumors. So the nutshell of WHO 2021 is that there are molecular markers everywhere. And this is the cartoon I made. And it seems like we're just touching the tip of the iceberg. And these are some of the molecular markers that are part of now ordinary conversation in tumor board. But there are actually many, many more to come. And they're already here. And next version of CNS classification, which will be coming in maybe 5 to 7 years, we are going to see even more. So what does this mean for radiologists? We just have to make sure that we know what is changing the field of classification of CNS tumors so that we could keep up with how we interpret imaging. So here's the nutshell of CNS WHO. There are so many molecular markers, and I'm only gonna touch on the several really important ones today. And at UCSF, instead of just getting a histopathological report, we get something like this. This is called UCSF 500 gene panel, where we actually get not just a histological diagnosis, but we get IDH status. But in addition to that, we get a whole host of additional information. And this is really becoming a part of our standard of care for brain tumor pathological diagnosis. So I'm going to show you a couple of cases, and we'll go over this at the end. You may not know the answer now, but I could assure you at the end of this 50-minute talk, you'll be an expert at it. So here's a young 19-year-old came with a diagnosis of stroke because of the ADC and DWI appearance, and end up having these molecular features when pathology was performed. Can you think of tumor type this could be? Second case, here are 3 very different histologic tumor types: pilocytic astrocytoma, ganglioglioma, and pleomorphic xanthoastrocytoma. Can you think of a molecular marker that these 3 tumors often, not always, but often share? So what is the molecular marker? Third, here's a tumor with very interesting appearing calcification. Does not enhance, has this heterogeneous T2 and diffusion abnormality. Can you think of a genetic marker that defines this tumor? How about this one? Here are 6 different patients with a large midline tumor, all pediatric patients. Can you think of a diagnosis and a molecular marker that all these 6 different patients share? And how about this one? 2 different patients with an extraaxial tumor, kind of look like meningioma, but they do not have the typical dural tail. This one looks very destructive. Can you think of a molecular marker that could unify these 2 at a very different type, but now we know that they're very related? How about this one? 2 different patients with posterior fossa ependymomas. Do you know the molecular genetic difference between the patient up at the top versus patient up at the bottom? And here are 4 different patients with 4 different types of medulloblastoma. Can you name the 4 main subtypes of medulloblastomas? So we will go over the answer at the end of this talk. So imaging, neuroimaging of 2023, still the most important technique is the structural MRI. We cannot interpret physiologic or any other fancier imaging technique without actually seeing what the tumor looks like on structural imaging. But we also do physiology-based MRI to assess for their vascularity, their metabolism. And another very important type of technique that we use is this hybrid imaging called PET-CT or PET-MR. And many institutions are beginning to use this technique to look at, is this a recurrent tumor or is this a radiation necrosis? So today I'm only going to highlight a couple of the structural and couple of physiologic MRI. And as I said before, structural MRI, post-con, pre-con T1, T2, FLAIR, multimodality, multiplanar imaging, this is the bread and butter of what we do, and this will never go away. But we put additional tests to look for hypervascularity. whether they're leaky permeability, and whether there is a hypercellularity or where there's high choline metabolism. So physiologic MRI gives us a lot of insight into very non-invasive way of glancing at their tumor biology. It's not as good as obviously actually looking at pathology, but it's a really powerful non-invasive tool. And this is what we do at UCSF, and it's pretty standard at most institutions, pre-post T1, T2 FSC flare, and DWI and ADC. ADC and DW, this is a must. And we also do SWI and ASL perfusion imaging. SWI is becoming more and more important in brain tumor imaging because we use this primarily to look for areas of blood products, especially after radiation therapy. And we use this for assessing where the extent of micro and macro hemorrhages, and also vascular lesions that are mimicking brain tumors. And primarily in the brain tumor arena, we use this to assess for the extent of radiotherapy related injuries. So here are 3 different patients with susceptibility weighted imaging. You could see this patient as literally innumerable punctate dots of susceptibility or microhemorrhage. This is a patient who received whole brain radiotherapy for medulloblastoma 15 years prior. Here's a patient with very peculiar looking branching pattern of SWI. This is a person with a venulitis. This whole thing was removed, and it's not glioblastoma. This is a venulitis or veins that are partially thrombosed. And this is a patient with very clear, large vascular mass, and that's cavernous malformation. So SWI, very helpful. Here's an example that we saw at tumor board. Patient had a rim enhancing, very aggressive looking right brachium pontus mass in the posterior fossa. But if you look at patients' SWI, there are innumerable punctate microhemorrhages. This is a telltale sign that patient probably had a radiation therapy. And lo and behold, we got the history after the fact. The patient had a nasopharyngeal carcinoma and a pituitary tumor that were radiated twice before. We did not have the radiation field, but with that history and with that SWI appearance, we feel very comfortable calling this radiation necrosis. And patient was treated for steroids to control some of the edema-related mass effect, and this lesion slowly disappeared. DWI, very important sequence. We use this to assess for acute infarct, abscess, cellular tumor, and actively demyelinating lesion. So here are 3 different patients. Here's the DWI imaging. Without even looking at structural imaging, when you see this homogeneous reduced diffusion with an irregular mass like this, this is a intracranial abscess until proven otherwise. Here's a patient, you can barely make it out. The lesion on DWI kind of disappears. This is what diffuse glioma looks like on diffusion. Here's a patient with 2 lesions, have a leading edge reduced diffusion. This is pretty classic for non-neoplastic, usually inflammatory, actively demyelinating type of lesion. And this young patient was biopsied, and that's a tumefactive demyelinating lesion. So diffusion is a must sequence when you're interpreting a brain mass. Here's another example. This patient came to us with a preoperative diagnosis from elsewhere, right frontal glioblastoma. I think that's not a bad diagnosis. There's a lots of mass effect. There's edema crossing the corpus callosum with central necrosis, rim of enhancement. But once you see the DWI and ADC, you know that there's homogeneous reduced diffusion within the necrotic tumor. So that is a very unusual appearance of a glioblastoma. So this is more classic appearance for pyogenic abscess. And indeed, pathology proved that this is pyogenic abscess. Our surgeons going in knew that this was going to be pus because we told them, and they end up just doing a little burr hole and sucking that pus out, and patient did great. Here's a young woman that I showed a little bit earlier. this young woman was diagnosed with stroke at an outside hospital. And you could see why. Why? Because there's actual homogeneously reduced diffusion, and it's very dark on ADC. But I think most of you would also notice that that shape is not a good shape for a territorial infarct. But nonetheless, patient was fine, the workup was negative, was transferred to our hospital, and patient underwent surgery. And this is a hypercellular, unfortunately, what's called a molecular glioblastoma. Perfusion, we use it to look for hypervascularity, hypervascular tumors. We also use perfusion to detect recurrent tumor, assess for glioma grade, and sometimes postictal changes. Here's a patient who came to us with a homogeneously enhancing right cerebellar mass. And you could see that DWI is not reduced. There's a little bit of a rim of susceptibility, but not much else. So the question is this a metastasis or something else? Patient did undergo whole body workup and there was no mass. And if you add ASL perfusion, you could see that the whole lesion is very, very vascular in the cerebellum. And this is pretty classic appearance for a hemangioblastoma. And that's indeed what it was on pathology. Here's a person who's been coming to us for serial imaging after patient had a subtotal resection. But you could see here that we don't know where the recurrent tumor here is. Patient had a seizure, they controlled the seizure. So after they controlled the seizure, we brought the patient back and did a perfusion imaging. And you could see that there is a clear, unmistakable lump of hypervascularity associated with non-mass-like flare here. So our neurosurgical colleagues went in and resected this hyperperfusion area. And the whole thing was a live recurrent diffuse glioma, IDH wild type. Spectroscopy, we use this tool now as a problem-solving tool. Here is a normal single voxel spectroscopy. Normal NAA, creatine, and choline. This is what you want to see. And we've done many spectroscopic studies, both 2D, single voxel, 2D, and 3D. But I still find this single voxel very powerful. And here's an example of some of our patients that we did on spectroscopy. Oh, by the way, a single voxel only requires about less than 3 minutes of imaging. So it's a really powerful tool that does not take up much in terms of additional imaging. And we've now kind of developed 4 different types of spectroscopic appearance of an abnormal lesion. So what we call the proliferative, where there's high choline, hypoxic profile, where there is clear lactate peak, infectious profile, where we see amino acids, alanine and acetate, and the necrotic pattern, where we see predominantly very high lipid and lactate. And here's an example of how we use this single voxel, 2 minutes of additional imaging. So this patient came to us with a left frontal glioblastoma as the preoperative diagnosis. Does look like glioblastoma with central necrosis. But once you get DWI, you know that inside of that rim enhancing lesion, there's a clear reduced diffusion that looks like pus. So we brought the patient down, and with a single voxel spectroscopy using TE of 35 milliseconds and 288 milliseconds. And we saw all the metabolites that classically seen in pyogenic abscess, such as amino acid, lactate, acetate, and the choline, which is not a tumor marker, it's a membrane turnover marker, is very, very low. So our confidence putting it together with the diffusion that this is going to be a pyogenic abscess was near 100%. And our neurosurgical colleagues just did a very small borehole and sucked out the fluid. And lo and behold, there is that yellowish purulent material. And this is a path-proven pyogenic abscess. So let me now focus more on the brain tumors based on the molecular genetics. And I'm going to start with 3 different types of pediatric tumors and go on to adult tumors. using the imaging techniques that I just described to you. So pediatric brain tumors in the WHO scheme from 2016 to 2021, many different classification changes have been made. The first is these two tumor types, one medulloblastoma, the other ependymoma. And you could see that without knowing anything about the tumor, so here's post-con T1, you could see that this patient has a tumor that is relatively homogeneously reduced on diffusion. So this is going to be some type of a cellular tumor. Patient, on the other hand, this tumor, both are midline enhancing lesion. You could see that DWI is not reduced. So DWI is single most helpful sequence after looking at post-contrast imaging. So we already know this patient has a hypercellular tumor, and that's a medulloblastoma. And this patient on the right, this is a patient with ependymoma. And DWI is really the first step towards honing down into the molecular or biologic feature of the tumor. So let's start with medulloblastoma. Medulloblastoma now genetically are divided into 4 main types. And these some of you are already familiar with, the Wnt, sonic hedgehog, and group 3 and group 4. And our colleagues from Stanford published this beautiful paper, and this was already 9 years ago, showing the imaging difference between the 4 subtypes, the Wnt, the sonic hedgehog, group 3, and group 4. And it turns out that Wnt type of medulloblastoma are almost always off midline, and they're not in the 4th ventricle only. They almost simulate a CP angle schwannoma. That's the Wnt type. Sonic hedgehog are usually the hemispheric tumors with this multinodular solid component. And there's 2 different types of it, but we are only going to just mention that this is a sonic hedgehog. And then these are the more common pediatric babies and infants can get this type of tumor where the tumor is in the dead midline, and some enhances avidly and some don't. And it turns out that the 4th ventricular midline tumor of medulloblastoma with avid enhancement are more likely to be group 3, and the less enhancing subtype tends to be group 4. I find this fascinating that imaging, although it's not 100%, can give us a glance into potential genetic and molecular subtypes. So here's the 4 main subtypes. How about ependymomas? So this is an interesting tumor too. So most of you are familiar that usually supratentorial ependymomas are intraparenchymal. The 4th ventricular or posterior fossa ones are inside the ventricle, and the cord one is in the intramedullary. I often wondered why we don't often see ependymomas right in the middle of 3rd or 4th lateral ventricle. Most of the ependymomas supratentorially that I've seen, they're all in the supratentorial parenchymal compartment. But then now all this genetic information is coming out. So 2016 and 2021 WHO now are classifying supratentorial ependymomas, particularly in pediatric age group, based on this very sophisticated molecular markers. So the relay fusion positive supratentorial ependymomas are one of the most aggressive ependymomas, more commonly occurring in pediatric age group, and they look even worse than some of the more really aggressive glioblastomas. And most of these ependymomas, particularly the relay fusion ones that I've seen, they tend to be intraparenchymal. But then when they do recur, they can recur all along the dural surface. So their biology is very different than the typical ependymomas that I've seen. So there are 2 subtypes that the WHO has clearly defined in the 2021 are the relay fusion and YAP1. I have yet to see a YAP1 molecular altered ependymomas, but like I said before, the supratentorial ependymomas in a young child, they tend to be this very aggressive molecular variant called relay fusion is the most common one that I've seen. And one thing that I want to stress that relay ependymomas, when they do recur, they can recur along the dura. So please, if you know the molecular feature, please look very closely at the dural margin because it may be the first sign of recurrence. How about intraventricular posterior fossa? So now we know clearly intraparenchymal supratentorial ependymomas and posterior fossa intraventricular ependymomas are genetically, molecularly, completely different. They may look similar on histopathology, but they are not related at all in terms of molecular genetics. So what are the two subtypes that WHO defined in the 2021? And the two subtypes are posterior fossa ependymoma type A, posterior fossa ependymoma type B. So what are the type A versus type B? So the type A looks like this. They almost look like a CP angle or lower medullary cistern tumor going out into the foramen luschka often. And this is called the PFA, or I call it the PF ependymoma asymmetric because it's off to the one side. And this is an awful prognostic ependymoma, and unfortunately much more common in pediatric age group. And then there's this subtype. The group B are the ones that sits usually in the midline, kind of simulate the appearance of a medulloblastoma. Group 3, because they are midline, enhances. But remember, ependymomas are not reduced on diffusion. And this is what I call the posterior fossa ependymoma that looks like a ball. But here you could see that they are actually very different. One is in the midline, one is asymmetric. And it also turns out that they're very different genetically. So PFA, I call it A stand for asymmetric. Group B, B stand for ball. So let's look at the tumor types a little more carefully. So here's group A, ependymoma type A, asymmetric off midline, and they tend to have more necrosis, hemorrhage, and these are much more aggressive component, and they have a unique genetic and molecular marker, very different from PFB, excuse me, and this is much more common in pediatric age group. Here's the PFB group, more like ball-shaped in the midline, and not as much as necrosis, little less hemorrhage, the midline location. And this is the type of ependymomas that tend to occur older children or adult patients. And their main presenting symptoms, they tend to present earlier because of the obstructive hydrocephalus, and they're very rarely invasive or infiltrative at all compared to the PFA variant. So here's PFA, the awful, much more prognostically worrisome type of ependymomas. And this, unfortunately, is much more common in pediatric age group. And they have a very specific molecular markers that are very different than PFB, the one that looks like a ball shaped in the midline posterior fossa. This is a ball shape. It's a better prognosis and affects adults a little bit more than pediatric age group. Now, moving on to second type of tumor that pediatric patients might get is the diffuse midline glioma. So these are tumors that are disorders primarily of a histone. And I think some of you know that each human cell DNA is about 1.8 meters, but thanks to histone, which winds down the DNA into 90 micrometers. But you could see that if there is a histone-related abnormality, it could lead to just devastating tumors like this, particularly the histone H3, K27M locus tends to cause tumors of this gigantic midline glioma. So comes the name of diffuse midline glioma, H3 K27M alter. So this is in 2021 version, changed its name, and it affects these midline structures, and they look like this. Just terrible tumor in the midline. Patient is sometimes very minimal symptomatically altered, but it's a tough tumor. Surgical resection is not a possibility because they tend to involve the deep thalamic nuclei like this. It's just an awful tumor. But here's the 6 different patients with the same awful diagnosis. And they're all, even though histologically they may look very different, but they have histone H3 K27M altered, and they tend to occur in the midline, and hence the name diffuse midline glioma. And some of these spinal cord tumor, and most of them now are called a diffuse midline glioma only when our pathologists can actually definitively identify the histone alteration, particularly H3K27M. And here's an example of a spinal cord. We used to call this spinal cord astrocytoma or glioblastoma, and that's not wrong. But once they get a tissue and our pathologists look for this particular mutation, that's how we know that this is a diffuse midline glioma, H3K27M altered. Here's a patient I saw, but what does it mean for radiologists? So we're not the one who's going to diagnose H3K27M molecular features, but I want you to remember that these are really terrible tumors. They sneak around. They actually can spread all along the CSF as if they are metastatic pineoblastomas or medulloblastomas. And keep an eye on brain. Any lesions in the brain cannot be ignored. So let me show you, this is one of our patients from many years ago when we first, our pathologists start to test for the H3K27M. After radiation therapy, our radiation oncologist did a great job. Some of these enhancing tumor looks better. The flare looks better too. But remember this original flare imaging of the brain? We were not sure whether this was really a real finding or is that a tumor. But 5 months later, you could see all of those areas are now nodular and patient recurred. And unfortunately, the real the tumor that they couldn't control was not the spinal cord diffuse midline glioma. It was the CSF ependymal leptomeningeal spread of the original tumor. And this is how diffuse midline glioma, H3K27M altered tumor, behave on follow-up imaging. So please make sure you get brain imaging to make sure we don't miss this very subtle lesions that show up on FLAIR imaging alone. These areas may not enhance at all. Adult tumors, I'm just going to show you some of interesting molecularly conjoined tumor types. One is this. So meningioma and hemangiopericytoma, back in the day when molecular genetics was not a thing in terms of our daily conversation, I used to think that meningiomas and hemangiopericytomas were related, and just that the hemangiopericytomas were much more aggressive and angrier looking and destroying the bone. And it turns out that molecular genetics have proven that these two tumors are not related at all. But it turns out that solitary fibrous tumor, which is a pretty rare extraaxial tumor that we see, but elsewhere in the body too, is intimately associated with hemangiopericytoma. Even though they look very different, this is what's called a grade 1, and hemangiopericytoma is grade 2 or 3. And they are related by this particular nuclear expression called STAT6. So WHO now lumps solitary fibrous tumor and hemangiopericytoma as a one single tumor type with a varying degree of aggression. So SFT is usually grade 1. Hemangiopericytoma is usually grade 2 and 3. And hemangiopericytomas can recur anywhere else in the body. But both these tumor types have STAT6 nuclear expression. And that is really needed to make the diagnosis of SFT and hemangiopericytomas in the brain. Here, the circumscribed tumor. And if you look at these three very different histologically, tumors have a nodule and a cyst, nodule and a cyst, nodule and a cyst. These are pilocytic astrocytomas, gangliogliomas, and pleomorphic xanthoastrocytomas. And some of the supratentorial of these three types share a molecular marker called BRAF V600E mutation. At our institution, some of these patients with this particular mutation, they have an anti-BRAF therapy they're in clinical trials for, and we are getting pretty good response to therapy. They're, again, three very different histologically, but imaging-wise, I always knew they kind of look similar because they share this shape, this pattern of nodule and a cyst, and a lot of these supratentorial pilocytics, ganglios, and PXAs have BRAF V600E mutation. Very interesting. And this is a paper from more than a decade ago that already looked at over 1,000 tumors, PXA, pilocytic, and ganglioma, and has shown that up to 60-70% of these tumors will harbor BRAF V600E mutation. So this work has been going on for decades, even though it now just made it to the 2016 and 2021 WHO. The work has been going on for decades to come to the fruition and make it into the classification scheme. So molecular glioblastoma, before I talk about molecular, let me tell you the classic glioblastomas. Here are 8 patients that I've known in the past, have the classic central necrosis, very aggressive, irregular rim of enhancement. These are all glioblastomas. And the classic GBM now have all these extra molecular genetic diagnoses that our pathologist is testing for, and some of them will be MGMT methylated, and some of you know the implication of MGMT hypermethylated GBM. These are actually the ones that respond quite well to temozolomide chemotherapy. But there's all these other things that they test for. But the unifying one is that all glioblastomas are IDH1 wild type. So there's no more what's called the glioblastoma IDH mutant does not exist anymore. All glioblastomas are IDH wild type. Now, what is molecular glioblastoma? These have a genetic mutation, the 3 component here, TERT promoter mutation, EGFR gene amplification, trisomy 7 and monosomy 10. And on imaging, they do not look like the classic glioblastoma I just showed you. This is that 19-year-old who was originally misdiagnosed as a stroke. If you look at her post-con imaging, it does not enhance at all. And on DWI, it has really hyper intense DWI signal intensity and very low ADC. This is a path proven molecular glioblastoma with these 3 molecular alterations: TERT promoter, EGFR, trisomy 7, and monosomy 10. And this is new. This is a separate tumor, but nonetheless, molecular glioblastoma are just as aggressive as classic glioblastoma. And this young lady who received TPA and cerebral angiogram looking for a source of stroke elsewhere came to us. This was resected. This is a molecular glioblastoma. But if you look down, patient has a second focus of additional tumor. And this is really bad news. Additional lesion, and that is the lesion that turns 5 months later into a frank glioblastoma. And this is a terrible prognostic situation. Diffuse gliomas, not to be confused with diffuse midline gliomas. Diffuse gliomas are what we used to call astrocytomas, oligodendrogliomas, or oligoastrocytomas. So we don't call oligoastro anymore. Diffuse gliomas are non-glioblastomas, and they're infiltrating either astrocytomas or oligodendrogliomas. And these are the 3 molecular markers that define diffuse gliomas. IDH being the most important. It signifies that it's going to be a lower grade. 1p19q, chromosome number 1, chromosome number 19, locus of code deletion. This is a disease-defining chromosomal marker for oligodendroglioma. ATRX is a marker defining astrocytoma. So at our institution, almost all diffuse gliomas on imaging and at initial pathology, a histologic analysis will undergo IDH for sure, and 1p19q to make sure that it's not an oligo. And if 1p19q is intact, then they will go ahead and do ATRX to prove that this is an astrocytoma. So this is how it's divided. Diffuse gliomas is either mutant or wild type. I already told you, wild type diffuse gliomas are de facto molecular glioblastoma. In the mutant variant, they will undergo 1p19q co-deletion testing. If that is deleted, that's an oligodendroglioma, period, end. If it's 1p19q intact, then ATRX is lost, then that's an astrocytoma. The wild type, these are much more aggressive tumors. If they have a TER promoter, EGFR amplification, trisomy 7 and monosomy 10, this is called the molecular glioblastoma. And diffuse astrocytoma IDH mutant was newly graded based on grade 2, 3, and 4 on WHO 2021. And this, the most aggressive variant, is now called the grade 4, but it has to have this particular molecular deletion called CDKN2AB homozygous deletion. But looking at the imaging, you could tell that this tumor is already trying to enhance, and there's some areas of central necrosis, but doesn't really look like a frank glioblastoma. You should think about grade 4 diffuse astrocytoma IDH mutant. And if your institution has the capability to do this molecular analysis, CDKN2AB homozygous deletion, this confirms that this is a grade 4 diffuse astrocytoma IDH mutant. IDH is the king right now of determining the fate of a glioma, whether it's going to glioblastoma route or diffuse lower grade glioma. It was discovered in 2008. And if there is a IDH mutation, it leads to this particular molecule, 2-hydroxyglutarate, accumulating. And it's much, much more common in lower grade gliomas. And in primary GBMs, it's almost never seen. But in some cases of a glioblastoma that dedifferentiated from a lower grade, you may actually detect this, but in classic glioblastoma, it's never seen. So what does this mean? That we at least have to know what IDH1 mutation, 1p19q co-deletion ATRX loss means, that I just already told you. So here's some of the tumors that this is from literature where T2 is super bright, flare, it becomes darker. This has been called a T2 flare mismatch. And this is not a 100% rule, but this has been described as T2 flare mismatch, meaning T2 is super bright, flare gets darker. This has been a imaging correlate of a diffuse astrocytoma IDH mutant ATRX loss. Not a 100% rule, but you could assess, at least guess before the surgery. Now, here's a patient with diffuse glioma. And how do I know it's more likely to be IDH mutant or wild type? The DWI is going to be one of the most helpful techniques. You could see that the tumor kind of disappears in DWI. This is more likely to be IDH mutant, the better prognostic glioma. This is that patient with molecular glioblastoma, non-enhancing, but look how very much aggressive the DWI looks. Very reduced on DWI, very dark on ADC. This is not a lower grade tumor at all, despite the fact that it hardly enhances, has apparent circumscribed border. This is not a good tumor. This is a IDH wild type. This is molecular glioblastoma. How about this one? This patient has a serpiginous looking calcium, and that calcific marker is pretty good, not a 100% rule for a specific type of tumor, and you could see that the fluorescent in situ hybridization, that's what that is, shows you that 1p 19q code deletion. You could see that there should be 2 pink and 2 green. Our pathologist confirmed for me, but there's 1 missing. So this is so-called the 1p 19q code deletion, and this is a disease-defining marker of an oligodendroglioma. We don't do CT anymore to confirm the presence of calcification. We may do SWI, but CT to confirm calcification is no longer standard of care practice. This is a patient, this is the last case that I'll share with you. He came back in 2003, and this was discovered after he had a car accident, and CT detected a low density lesion. So he was completely asymptomatic. I looked at this and I said, I'm not sure if it's tumor. So why don't we just get serial imaging? So he came back every year, and then it started to grow in about 3 years. Here's 2012. So 9 years, this lesion has almost doubled. So I scratched my head and said, does lower grade gliomas grow this slowly? Probably could. But during 2020, patient emailed me and said, can you take a look at my MRI? And I look at it, and I look at from the 2003. So these are 17 years apart. And I explained to the patient, this is growing. We no longer can just sit around and do nothing. And our neurosurgical colleagues, after hearing my brain tumor talk about 2HG, he said to me, why don't we get a 2HG MRS? And I thought, brilliant idea. So we brought the patient to our research scanner, and our outstanding postdocs and PhDs there helped us to do a 2HG scan. And lo and behold, this patient within this lesion had an unmistakable, not an artifactual, a 2-hydroxyglutarate peak that you can only really see in IDH mutant gliomas. So this pushed us over the edge. Patient went for surgery, gross totally resected, and this is a gross totally resected IDH mutant 1p19q co-deleted oligodendroglioma. And this is the first time that I was just stunned at how this non-invasive technique really helped us. So this is already 3 years ago now, and patient is doing very well. That 2HG is indeed a marker for IDH mutant gliomas, and this happens to be an IDH mutant oligodendroglioma. So let's go over some of the cases that I showed you earlier. Patient has these 3 molecular markers altered. So what is the tumor type? I showed you this case already twice with this really profound reduced diffusion, young lady who were initially thought to have a stroke. Unfortunately, this is a molecular glioblastoma. How about these 3 tumor types? Pilocytic, ganglio, PXA, they all share sometimes this nodule and a cystic appearance. What would be the defining molecular markers? The BRAF V600E mutation. How about this tumor that I just showed you? Calcification. This is a 1p19q code deletion of an oligodendroglioma. So if you see a tumor and you happen to have a CT and you see calcium and putting together with MRI features, you could be with reasonable confidence tell that this is going to be an oligodendroglioma. And if you're ever doubt, you can actually do a 2HG MRS scan and see if you can detect 2HG. That will be a slam dunk that this is an IDH mutant tumor. How about this one? Midline, just awful looking expansile tumors in pediatric age group. What would be the histologic marker and diagnosis? This is diffuse midline glioma, H3 K27M altered. These are histone mutated, really aggressive tumors. How about these 2 tumors? Extraaxial tumors, not a meningioma, but they are joined together. SFT and hemangiopericytoma. What is the molecular marker that defines these 2 tumor types into one? That's the STAT6 nuclear expression. We already discussed the two different types of posterior fossa ependymomas. They're completely different genetically. One is called the PFA, the asymmetric type. The other one is called the PFB, as in ball-shaped in the midline. A is asymmetric, pediatric age group, and it's an awful prognosis. The one in the midline looks like ball-shaped. These are better prognostic, and very rarely these will be infiltrated. So the two different types, subtypes of a posterior fossa ependymomas are posterior fossa ependymoma type A. The other one is posterior fossa ependymoma type B. B is better ball-shaped. PFA is asymmetric, and it's an awful prognosis. The four main subtypes of medulloblastomas, we already discussed this. The one that is off midline kind of looks like CP angle or lower cranial nerve schwannoma. That actually is one of the best prognostic subtype of the medulla, and that's the WNT. Hemispheric, multinodular, solid, aggressive-looking, reduced on diffusion. That is going to be the sonic hedgehog. Two midline tumors, reduced on diffusion. One enhances more avidly, the other one is less enhancing. The one that enhances more is the group 3, and the less enhancing midline medulloblastomas are the group 4. So here's your main 4 molecular genetic subtypes of medulloblastomas. And imaging, not as good as pathology or molecular genetics or UCSF 500 gene panels, but it does a pretty decent job guesstimating what the molecular genetic abnormality might be of a given tumor. So with that, I would like to summarize that I gave you some highlights of 2021 WHO CNS Tumor Classification, but I also want to highlight that this is a field that's evolving every year. So the next version, which I am told might come out in 2025 or 2026, may actually have even more molecular genetic markers. So please stay tuned about that. And I showed you some update on structural and physiologic MR, like diffusion being super important to differentiate abscess versus glioblastomas, cellular versus less cellular tumors, and MR perfusion to detect recurrent high-grade gliomas, and spectroscopy methods that you can actually detect some of the oncometabolite associated with IDH mutant, such as 2-hydroxyglutarate. And the imaging correlates of molecular and genetic profiles of CNS tumors, an example being the 4 subtypes of medulloblastoma and 2 subtypes of ependymomas that you could actually guesstimate, not 100% rule, but with a reasonable confidence, you could predict their molecular subtypes without ever touching a tissue or doing a craniotomy. I think imaging is such a powerful technique and it's non-invasive. So we are in a very interesting and very important field. And as I said, molecular generic era of CNS tumors is here. It's only going to get more complex and advanced, and imaging must keep up with its pace. So with that, I thank you for your attention, and I will stop sharing my screen and take any questions. So I think we got some in the chat Q&A. Where does ATRT stand in this classification? So ATRT stands for atypical teratoid rhabdoid tumor. This is actually a tumor that is super aggressive, but they're not medullos, they're not ependymomas, and they have their own very specific molecular marker called INI1. So our pathologists can specifically test that molecular marker to differentiate, because ATRT can look just like medulloblastoma, can just like aggressive ependymomas, the PFA. So we actually have our pathologists have the power and method to identify ATRT. There's no formal classification of ATRT yet, but it might be next time, next version might include that. But like I said, the molecular marker that defines ATRT is this enzyme called INI1 mutation. If that is altered, that's an ATRT and nothing else. Next question. Since gliomatosis cerebri is obsolete now, what is to be labeled according to recent recommendation? This is an excellent question. Even though WHO said don't use this, frankly, at Tumor Board, I use this term because some tumors, entire hemisphere is all infiltrated with non-enhancing flare bright lesion. Nothing is enhancing, nothing is reduced. So now I use the term, this is the gliomatosis cerebri pattern of diffuse glioma. But these are usually, when they do go for pathology, they are IDH mutant tumors, and they're not oligos. I've never seen gliomatosis cerebri tumors that are actually oligo or 1p19q code deleted. So yes, it's obsolete, and yet we still use this term. Is the term relay fusion still used, or is it outdated? Another good question. No, it's the WHO 2021 came up with this ZFTA, some other name, but in our tumor board, we still use the term relay fusion because everybody understands what that is. But the molecular genetic term has become much more complicated. But when I'm reading out with a trainee, we look at the electromedical record. And if we see the term relay, we know that we have to really look for odd places for recurrence. That's really what's important here. That relay fusion ependymomas tend to occur, at least maybe half a dozen cases that I've seen, in the dural surfaces. So the probably next version might end up just getting rid of relay altogether, but we still use it. And that term is still exists in the very complex pathology report. So you could search for it as well. Is there any other question? Let me just do that. There's a chat here.
There's a chat about your painting, if you want to say what painting that is.
So this is Georgia O'Keeffe. This is not an actual real painting, but if anybody would like to donate this to me, I will be forever grateful. Just kidding. This is one of the most beautiful painting that I've ever seen. This is a Georgia O'Keeffe's. I don't know the name. I think she just named it Flower, but I've been using this for the entire pandemic, and thank you so much. So there's no molecular marker associated with this painting. Is there anything else that I could answer for our outstanding audience?
I think that's it. Dr. Cha, thank you so much for your lecture today. Really.
Oh, thank you. Thank you so much, everyone. Have a wonderful rest of the week. And thank you for this opportunity again. Bye-bye.
Absolutely. Thank you. And thanks for everyone for participating in our noon conference. You can access the recording of today's conference and all our previous noon conferences by creating a free MRI Online account. Be sure to join us next week on Thursday, September 21st at 12 p.m. Eastern. We're featuring Dr. Sheila Sheff for a noon conference entitled Peripheral Vascular Ultrasound, Venous Doppler, and Challenging Arterial Cases. You can register for this free lecture at mrionline.com and follow us on social media for updates on future noon conferences. Thanks again and have a great day.